Now moving on to the second and final section of the wrist part of the course, we are going to spend the next few minutes identifying common wrist pathologies seen on X-ray. We are going to start out by talking about distal radius fractures, as these are a very, very common injury seen in the emergency room and in clinics that most physicians will encounter at some point. No matter what field you're in, it's good to have a basic knowledge of distal radius fractures. They usually occur from this foosh, fallen outstretched hand mechanism, and many hand and wrist pathologies are the result of this as well. Distal radius fractures are especially common in the elderly and pediatric populations, and the type of distal radius fracture can be categorized by the fracture pattern. Because they are so common, many of the fracture patterns have been named and are characterized based on whether the fracture is intra or extra articular and which anatomic area of the radius is affected. The 5 common types of distal radius fractures that we will discuss are the Colles fracture, which is an extra-articular dorsal fracture, the Smith, also extra-articular but volar, Barton, intra-articular rim fracture, die punch, intra-articular lunate fossa, and the chauffeur fracture, which is an intra-articular radial styloid fracture. So these are all variations of distal radius fractures. The first type of distal radius fracture that we will discuss is a Colles fracture. This is a fracture of the metaphysis or the neck of the radius, as shown here, making it an extra-articular fracture, so it does not involve the joint. Colles fractures have a characteristic dorsal displacement of the distal segment. So you can see in this diagram here that the distal segment is displaced dorsally. Here on the PA view, you can't see the dorsal displacement, but you can see that it is an extra-articular fracture. You may hear this fracture described as a dinner fork deformity because the displaced distal segment causes a bump on the dorsal hand. So you can see the bump there that kind of resembles a dinner fork. Here are 2 good X-ray examples. So you can see how the fracture line does not extend into the joint there. And then on the lateral view, that's where you can really see the distal segment is causing this dorsal bump on the wrist. The other common type of extra-articular distal radius fracture is a Smith fracture. It is basically the same mechanism and fracture type as the Colles fracture, but it has opposite angulation. While Colles has the distal segment going dorsally, Smith has it going volarly, and this is because of the mechanism. So the mechanism for a Colles fracture is landing on your hand like this, while as for Smith, you're landing on the dorsum of your hand, and that causes opposite angulation. So here is a radiographic example of a Smith fracture. So very similar to the Colles fracture in that it's an extra-articular fracture. However, this time the distal segment is displaced volarly compared to the proximal segment, which is more dorsal. So it's a volar distal radius fracture. The next and final 3 types of distal radius fractures that we are going to discuss are all intra-articular, so involving the wrist joint, so between the radius and the proximal carpal row. The first type is the Barton fracture, and this is an intra-articular fracture of the rim of the radius. So the rim of the radius is the kind of raised lip all the way around the bone circumferentially. Barton's fractures can involve either the dorsal or volar rim, but it is usually dorsal. So you can see here, there's the fracture line extending into the joint, making it intra-articular. And then you can see here on the lateral view that it involves the dorsal rim rather than the volar rim. Because it is an intra-articular fracture, there's usually associated dislocation of the radiocarpal wrist joint. However, in this image, you don't see any dislocation. Another type of intra-articular fracture is called a die punch fracture, which involves the lunate fossa. So recall that the distal radius has 3 articulating surfaces. So it has the scaphoid fossa, the lunate fossa, and the sigmoid notch. And so in this fracture type, the die punch fracture, it is a break in the distal radius where the lunate sits in the lunate fossa. So in the process of breaking the distal radius, the lunate fossa becomes depressed downwards, and it creates more space between the lunate and the distal radius. It is named a die punch fracture after the piece of machinery that was called a die, which is a block of metal that kind of punches shapes into other metal, such as the tool used to make coins. In the same way, the lunate punches a lunate-shaped depression in the distal radius in its lunate fossa. So you can see here a diagram of that, and this is a die punch fracture. So you can see the lunate there, and force has caused it to punch downwards into its lunate fossa, and it creates this lunate-shaped depression. You can see two examples of this here, where there's an intra-articular fracture that extends into the lunate fossa with associated depression of the lunate fossa. So you can see here that it's kind of this lunate-shaped depression in the distal radius. And you can see here that there's a small kind of step-off deformity. The final type of distal radius fracture we will discuss is the radial styloid or chauffeur fracture. This is once again an intra-articular fracture that involves the radial styloid. So in the image, you can see that the radial styloid is a projection of bone on the radial lateral side of the radius. You can feel it on your own wrist as the projection of just where your forearm meets the base of your thumb. These are called chauffeur fractures because back in the olden days when automobiles were invented, drivers had to start the car by turning a crank clockwise furiously. Sometimes the motor would start unexpectedly and the crank would spin backwards and hit the driver's wrist. The radial styloid extends out that side of the wrist, and so it was the most vulnerable area and most commonly hit. And so chauffeurs would often suffer this type of distal radius fracture of the radial styloid. While that particular mechanism doesn't happen very often these days, usually this type of chauffeur fracture is caused now by either a direct blow to the wrist, similar to the chauffeur mechanism, or from forced dorsiflexion with abduction. Here's a diagram showing the radial styloid. So it's kind of a wedge out of the radial styloid. And then here are two radiographs where you can see that quite clearly, that there's a fracture extending into the joint line, and then it's this wedged shape that's cutting off the radial styloid. Once again, you can see that fracture there. Now that we have finished up with the common types of distal radius fractures, we will move on to the last section where we will discuss some common carpal pathologies. So first and foremost, we have scaphoid fractures. This is the most common carpal bone fracture, and it usually happens with a fouche, fallen outstretched hands injury. The scaphoid can be classified anatomically with a proximal pole, a waist, and a distal pole. Fractures can occur in any of these areas, and we name the fracture based on where it is, i.e., you can have a distal pole fracture, a waist fracture, or a proximal fracture. What is unique about the scaphoid is that most of the blood supply is from a retrograde blood flow. So this means that the artery arrives from the distal ends and then travels backwards from the distal end through the waist to provide the more proximal pole with oxygen and nutrients. So when you break the scaphoid, especially at the proximal end, which is further away from the entrance of blood flow there, it leaves the proximal pole unattached from the rest of the scaphoid and thus unattached from the blood source. This creates a poor healing environment for fractures especially. If the scaphoid doesn't get adequate blood supply, it is at a high risk of non-union and osteonecrosis, as well as long-term pain and arthritis. So this can be a very serious injury. As a result, it is very important to identify scaphoid fractures either radiologically or clinically. Sometimes they're easy to identify on x-ray, so like in this image, you can see clearly that boat-shaped scaphoid has a very clear waist fracture. Here is another example. This time you can see the scaphoid is outlined here by my cursor, and you can see that there is a distal pole fracture. And then finally, the last type would be a proximal pole fracture, and you can see that here, that just at the proximal end, there is a fracture line on x-ray. However, sometimes it is not so easy to identify scaphoid fractures. Often patients present with no obvious fracture on the x-ray, but significant pain in the area between the extensor pollicis longus tendon and then the extensor pollicis brevis and abductor pollicis tendons. So right in this area here, that's what's called the anatomic snuff box, and it's just overlying the scaphoid. The anatomic snuff box is called that because in the olden days, people placed powdered tobacco known as snuff in that depression formed between those tendons, and they would be able to sniff it from that depression. As a clinician, if you have a high clinical suspicion of a scaphoid fracture, so they had a fouche fall injury, they have tenderness in that anatomic snuff box, but no fracture is seen on the x-ray, this is called an occult fracture. These may require more advanced imaging, such as a CT scan, and may be treated as a scaphoid fracture, even in the absence of an obvious fracture on an x-ray. For example, this x-ray shows no obvious fracture of the scaphoid, but the scaphoid was found to have a fracture on further imaging, illustrating that sometimes it can be very difficult to identify. So if you look closely, it's very, very difficult to actually identify any clear scaphoid fracture, but based on clinical suspicion, it should be treated as a scaphoid fracture. So just to recap, because this is a very important point, just because you don't see a scaphoid fracture on an x-ray doesn't mean that there isn't one. You can always move up to further imaging like a CT scan, but if there's a confirmed or suspected scaphoid fracture, patients should all be casted and referred to plastic surgery or orthopedic surgery, depending on who covers that in your center, for management, because all types of scaphoid fractures, not just proximal pole, are at risk of poor healing and long-term problems if they're not managed properly. The second most common type of carpal fracture is of the triquetrum bone. So recall that the triquetrum is also in the proximal row beside the lunate on the ulnar edge of the wrist. These fractures are also usually fouche injuries when the hand is turned out in ulnar deviation. You can see a triquetrum fracture here on the oblique view. So that just emphasizes the need for multiple x-rays views because it may not be obvious on PA or lateral, but you can see a clear fracture there. Notably, triquetral fractures are often best seen on the lateral view, as you may be able to see the pooping duck sign. So on lateral x-ray, you can see that the scaphoid forms this yellow duck body. The lunate is this blue outline that's moon-shaped, and then the triquetrum is the duck's bum that is outlined in green here. Sometimes in triquetral fractures, there's an avulsed fragment that looks like it's being pooped by a duck. So you can see there's a small avulsion fracture there that looks like it's being pooped out by the duck. This is only relevant when there's an avulsion fracture as opposed to a transverse fracture or other types, but is also a good way to identify the scaphoid on lateral view. So if you're just looking for the scaphoid when you're looking at a lateral view of an x-ray, you can always remember it as the main body of that duck. So here is an example. So this is the opposite way of these photos here, but you can see the duck's little face there. You can see the body of the duck, which is the scaphoid. You can see the lunate forming the bottom of the duck. And then just peeking out there, you see that avulsion fracture. And so that shows us that there is a positive pooping duck sign, which is indicative of a triquetrum fracture. We will next touch briefly on lunate and perilunate dislocations. Perilunate or lunate dislocations happen generally with great force applied to the wrist, such as with a fouche injury or with a motor vehicle collision, more commonly. The lunate is a proximal row carpal bone that sits just beside the scaphoid, as we've discussed, and articulates with the radius in the lunate fossa, as well as the capitate above it. So here on lateral view, you can see that the radius, lunate, and capitate are all in a nice straight line, and that was one of our 4 A's of examining carpal bones. That was alignment. Lateral views are the best view for identifying perilunate and lunate dislocations because you can see the lunate well. So once again, here is an actual radiograph showing that. So the radius, and then you have the lunate that's sitting nicely in that cup and saucer with a capitate sitting there nicely in line as well. So that shows good alignment. Perilunate dislocations are more common than lunate dislocations, and they happen when the articulation between the capitate and the lunate is disrupted. So in this example, you can see that the lunate and capitate are kind of completely out of alignment with the capitate here. and the lunate here, so definitely not a cup and saucer. However, the radius and lunate are still in okay alignment. The lunate is still sitting in its lunate fossa there, but the capitate is completely misaligned. So that would be a perilunate dislocation. In contrast, a true lunate dislocation involves the complete dislocation at both intersections, so with the capitate above and the radius below. So the lunate is left floating unattached to either the radius or the capitate, so there's no cup and saucer. This results in the characteristic spilled teacup sign, where the lunate, shaped like the little moon or teacup in this case, is completely upside down and displaced volarly into the palm of the hand, or just kind of volarly over the wrist there. It may not always be as extreme as this example, but you can see that even in the second image here, you can see that it looks like a teacup being spilled, and you can see that the lunate has now completely lost its articulation with the radius as well as the capitate. So that would be a complete or full lunate dislocation. Once a lunate or a perilunate dislocation is identified, the patient should receive an urgent referral to plastic surgery, and no attempts in the emergency room should be done to reduce the lunate without consultation of plastic surgery. This is because these dislocations into this volar wrist area can actually cause median nerve compression, and attempts to reduce the bone by pressing on the lunate, because it'll be reduced there, if you press on it, that can actually damage the median nerve even more. And so we have to be very careful with those. Finally, we have a scapholunate dissociation. So scapholunate dissociation is as it sounds. Normally the scaphoid, as seen here, and the lunate carpal bones in the proximal row articulate with each other with a 1 to 2 millimeter gap between them, as seen in this normal x-ray. And so remember, we discussed the 4 A's, and this would be articulation, 1 to 2 millimeters between them. However, the scaphoid and lunate can become dissociated. So normally these two bones are held together by a very strong ligament called the scapholunate interosseous ligament, or SLIL. So when there's a dissociation of the bones on x-ray, it implies an injury to the ligament holding them together. Because of this, the terms scapholunate dissociation and scapholunate interosseous ligament injury are often used interchangeably. So when we compare this image, this radiograph here, to the radiograph on the previous slide, we see that there is a significant gap here between the scaphoid and the lunate that is significantly more than the normal 1 to 2 millimeter cutoff. Generally, the abnormal cutoff is greater than 3 to 4 millimeters, so this would qualify. When there is a gap this large between the scaphoid and the lunate, this is called the Terry Thomas sign. So Terry Thomas was a British comedian with a large gap between his two front teeth, and the gap between the scaphoid and the lunate seems to resemble his smile with a gap tooth in the middle. As a result, the Terry Thomas sign is pathognomonic for a scapholunate dissociation, or an injury to the ligament between the scaphoid and the lunate. Often these patients present several days after an injury with minimal pain and swelling and no fractures, so this is a good one to look out for because the finding is a little bit more subtle on the x-ray. That brings us to the end of the carpal bone module.